In general, a lumbar puncture is not done when a patient has increased intracranial pressure or if we suspect an increase in intracranial pressures. The reason for this is that cerebral herniation could occur from the sudden release of the pressure in the skull from the area above the lumbar puncture. Now, a lumbar puncture is routinely done to obtain CSF for testing. Okay, this CSF can be tested for the presence of cancer, infection, and degenerative brain diseases. During this procedure, the nurse is responsible for positioning the patient. As you see, the side-lying fetal position here is the position of choice for the lumbar puncture. It's always a concern to watch the site for bleeding afterwards. Okay. Now, as we go forward, we're also going to discover that there is an exception to this rule about not doing a lumbar puncture on somebody who has suspected increased intracranial pressure, and that would be to use the lumbar puncture to remove excess cerebral spinal fluid, creating more space within that cranial vault for an expanding cerebrum, for example, or brain swelling. So you can actually lower the intracranial pressure through the use of a therapeutic lumbar puncture. Now, I know that gets confusing for students. The general rule is not to do a lumbar puncture with increased intracranial pressures because it can lead to cerebral herniation. However, when a patient has increased intracranial pressures, the physician can also make the decision to remove some CSF to create space within that cranial vault and bring down intracranial pressures. Intracranial pressure monitoring is used to guide clinical care when the patient is at risk for or has elevations in intracranial pressure. It may be used in patients with a variety of neurological problems, including hemorrhage, stroke, tumor, infection, or traumatic brain injury. Intracranial pressure should be monitored in patients admitted with a Glasgow Coma scale of 8 or less and an abnormal CAT scan or MRI. These results indicate that the patient may have bleeding, a contusion, edema, or other problems. We will discuss the Glasgow Coma scale in a later presentation. Methods of measuring intracranial pressure. Patients with conditions known to elevate intracranial pressure, except those with irreversible problems or advanced neurological disease, usually undergo intracranial pressure monitoring in an ICU. Multiple methods and devices are available to monitor ICP in various sites. The gold standard for monitoring intracranial pressure is the ventriculostomy, in which a specialized catheter is inserted into the lateral ventricle and coupled to an external transducer. This technique directly measures the pressure within the ventricles. It can also be used to facilitate removal and/or sampling of the CSF, and also allows for drug administration directly to the brain. So we can also use the intracranial pressure or ventriculostomy device for intraventricular drug administration. Remember that there are many drugs that are unable to cross the blood-brain barrier. So if we wanted to treat an infection in the brain, this might be one way in which we could administer antibiotics. In this system, the transducer is external. Placing a ventriculostomy catheter requires the creation of a burr hole, which is an opening into the cranium with the use of a drill. So it's used to remove fluid and blood beneath the dura, and also allows for placement of a ventriculostomy catheter for measurement of intracranial pressures. Infection is a serious complication with intracranial pressure monitoring. Factors that contribute to infection include ICP monitoring more than 5 days, use of a ventriculostomy, a CSF leak, and a concurrent systemic infection. It's very important for the nurse to routinely assess the insertion site, to use aseptic technique, and monitor the CSF for a change in drainage color and clarity. So if the CSF that is draining becomes cloudy, then that would indicate that there is bacterial infection. So that visual inspection of the clarity is important. As well, we would monitor our patient's temperature. An elevation in temperature could indicate the beginnings of an infection within the brain. Knowing the ICP lets the clinician calculate cerebral perfusion pressure by subtracting the ICP from the mean arterial blood pressure. Treatment goals include achieving a cerebral perfusion pressure of greater than 60 millimeters of mercury by controlling the ICP and ensuring an adequate systemic blood pressure. Now, those goals have changed, and it used to be that we wanted to keep the CCP greater than 70 millimeters of mercury, but that has recently changed, and the goal now is to achieve a CPP greater than 60. The absolute intracranial pressure value that should be deemed unacceptable is unclear, but the threshold generally used for treatment is an ICP of 20 to 25 millimeters of mercury. Okay, the patient's response to each intervention must be closely evaluated to monitor the effectiveness of treatment and determine whether additional interventions are needed. With the ventricular catheter, it is possible to control intracranial pressure by removing CSF. The healthcare provider typically orders a specific level at which to start drainage and the frequency of draining, whether it's intermittent or continuous. When the ICP is above the indicated level, the system is opened by turning a stopcock and allowing the drainage of CSF, thus relieving pressure inside the cranial vault. And although CSF removal decreases intracranial pressure and improves cerebral perfusion pressure, there are no universal guidelines for CSF removal. Guidelines are typically provided or based on the agency or the healthcare provider's preference. In other words, the physician will make those determinations. The ventriculostomy is a valuable device for measuring the pressures within the ventricles, for facilitating removal of cerebrospinal fluid. It allows for sampling of cerebrospinal fluid, and it allows for intraventricular drug administration. But complications can occur, including ventricular collapse, infection, and herniation, or subdural hematoma formation from rapid decompression. Strict aseptic technique during dressing changes or sampling of CSF is crucial to prevent infection. The system must stay intact to ensure that the intracranial pressure readings are accurate, because treatment is based on those pressures. In this system, it is important to ensure that the transducer is level with the foramen of Monroe, which is your interventricular foramen. The system must also be at the ideal height. A reference point for this foramen is the tragus of the ear. Every time the patient is repositioned, it's important to assess that the system is still level. So, assess the system to ensure it is level before taking intraventricular readings of pressure. Measurement of the intracranial pressure is a valuable tool for evaluating changes with patient condition. It is important to monitor the ICP waveform and the mean cerebral perfusion pressure. We can also consider the rate at which changes occur and the patient's clinical condition. Neurologic deterioration may not occur until the ICP elevation is pronounced and sustained. Immediately report to the healthcare provider any intracranial pressure elevation, either as a mean increase in pressure or as an abnormal waveform configuration. And as always, prevent and monitor for infection. As mentioned earlier, the ventricular catheter can allow us to control the intracranial pressure by removing cerebrospinal fluid, whether that is intermittent removal or a continuous drainage system. It's also nice to note that CSF is normally produced at about 20 to 30 mLs per hour. Okay? So careful monitoring of volume of CSF that has been drained is essential, and of course, always remember that we have a catheter directly into the brain, and so there is a great risk for infection. The goals of interprofessional care are to identify and treat the underlying cause of increased intracranial pressure and to support brain function. The earlier the condition is recognized and treated, the better the patient outcome. A careful history is important in the search for the underlying cause. The underlying cause of increased intracranial pressure is usually an increase in blood due to hemorrhage, brain tissue because of a tumor or swelling or edema, or CSF in the brain, which is referred to as hydrocephalus. For any patient with increased intracranial pressure, it's important to maintain adequate oxygenation to support brain function and prevent secondary injury. An ET tube or tracheostomy may be needed to maintain adequate ventilation. Arterial blood gases are analyzed to guide oxygen therapy. The goal is to maintain the partial pressure of dissolved oxygen in the blood at 100 millimeters of mercury or greater, and to keep the partial pressures of CO2 in the normal range of 35 to 45 millimeters of mercury. The patient may need to be on a mechanical ventilator to ensure adequate oxygenation. If increased intracranial pressure is caused by a mass lesion, for example, a tumor or hematoma, surgical removal of the mass is the best treatment. In aggressive situations, a craniectomy may be done to reduce intracranial pressure and prevent herniation. A craniectomy is the removal of part of the skull. The term cranioplasty refers to repair of a cranial defect resulting from trauma, malformation, or a previous surgical procedure. Artificial material is used to replace damaged or lost bone. A craniotomy is an opening into the cranium with removal of bone flap and opening the dura to remove a lesion, repair a damaged area, drain blood, or relieve increases in intracranial pressure. Depending on the location of the pathologic condition, a craniotomy may be frontal, parietal, occipital, temporal, or a combination of any of these. The healthcare provider drills a set of burr holes and uses a saw to connect the holes to remove the bone flap. After surgery, the bone flap is secured with small plates or wired shut. Sometimes drains are placed to remove blood and fluid. Patients are usually cared for in an ICU until stable. Shunts and shunt procedures are used as alternative pathways to redirect cerebrospinal fluid from one area to another using a tube or implanted device. Examples include a ventricular shunt. Drug therapy plays an important role in the management of increased intracranial pressure. Mannitol, also called osmetrol, is an osmotic diuretic given intravenously. Mannitol decreases intracranial pressure in two ways, through plasma expansion and osmotic effect. The immediate plasma expanding effect reduces the hematocrit and blood viscosity. This increases cerebral blood flow and cerebral oxygen delivery. A vascular osmotic gradient is created by mannitol. Thus, fluid moves from the tissues into the blood vessels, reducing the intracranial pressure because of the decrease in the total brain fluid content. Monitor fluid and electrolyte status when osmotic diuretics are used. Mannitol may be contraindicated if renal disease is present and serum osmolality increased. Hypertonic saline solution is another option. It produces massive movement of water out of edematous swollen brain cells and into blood vessels. This movement can reduce swelling and improve cerebral blood flow. Corticosteroids, such as dexamethasone, are used to treat vasogenic edema around tumors and abscesses. These drugs are not recommended for traumatic brain injury. Corticosteroids stabilize the cell membrane and inhibit the synthesis of prostaglandins, preventing the formation of pro-inflammatory mediators. Corticosteroids also improve neuronal function by improving cerebral blood flow and restoring autoregulation. Complications associated with the use of corticosteroids include hyperglycemia, increased incidence of infections, and GI bleeding. Regularly monitor fluid intake and sodium levels. Perform blood glucose monitoring at least every 6 hours. Patients receiving corticosteroids should receive antacid, histamine receptor blockers, or proton pump inhibitors to prevent GI ulcers and bleeding. Pain, anxiety, and fear can increase intracranial pressure and blood pressure, thus complicating the patient's management and recovery. Giving sedatives, paralytics, and analgesics for symptom management is a challenge, as these agents may alter the neurologic status, thus masking true neurologic changes. It may be necessary to temporarily stop drug therapy to appropriately assess neurologic status. Opioids such as morphine and fentanyl are rapid onset analgesics with minimal effect on the cerebral blood flow or oxygen metabolism. The IV sedative propofol, or also called Diprivan, is used to manage anxiety and agitation in the ICU because of its rapid onset and short half-life. An accurate neurologic assessment can be done soon after stopping an infusion of propofol. Medications such as dexamethasone, also called Decadron, as well as methylprednisolone or solumedrol, are useful in reducing cerebral edema. Additionally, mannitol, also called osmetrol, is an excellent osmotic diuresis in treating cerebral edema. Neuromuscular blocking agents such as vecuronium or cisatracurium, also called Nimbex, are useful for achieving complete ventilatory control in the treatment of refractory intracranial hypertension. Because these agents paralyze muscles without blocking pain or noxious stimuli, they are used in combination with sedatives, analgesics, or benzodiazepines. During drug therapy for reducing cerebral metabolism may be an effective way to control intracranial pressure. Reducing the metabolic rate decreases the cerebral blood flow and therefore the intracranial pressure. High doses of barbiturates, such as pentobarbital or thiopental, are used in patients with increased intracranial pressure refractory to other treatments. Barbiturates decrease cerebral metabolism, causing a decrease in intracranial pressure and a reduction in cerebral edema. Metabolic demands such as fever, agitation or shivering, pain, and seizures can increase intracranial pressure. Implement measures to reduce these metabolic demands to lower the intracranial pressure in the at-risk patient. Monitor patients for seizure activity. They may need prophylactic anti-seizure medication. Maintain the temperature at 98.6 degrees Fahrenheit or 36 to 37 degrees Celsius by using antipyretics such as acetaminophen, cool baths, cooling blankets, ice packs, or intravascular cooling devices as needed. Avoid letting the patient shiver or shake, since this increases the metabolic workload on the brain. If this occurs, the patient may need sedatives or a different cooling method. Intravenous 0.9% normal sodium chloride is the preferred solution for giving secondary medications. If 5% dextrose in water or half normal saline is used, serum osmolarity decreases and an increase in cerebral edema may occur. Subjective data about the patient with increased intracranial pressure can be obtained from the patient, caregiver, or family member who is familiar with the patient. Describe the level of consciousness by noting the specific behaviors seen. Assess the level of consciousness using the Glasgow Coma Scale. Assess body functions, especially circulation and respiration. The Glasgow Coma Scale is a quick, practical, and standard system for assessing the level of consciousness. The three areas assessed in the Glasgow Coma Scale are the patient's ability to open the eyes when a verbal or painful stimulus is applied, speak, and obey commands. Specific assessments evaluate the patient's response to varying degrees of stimulus. 3 indicators of response are evaluated: opening of the eyes, best verbal response, and best motor response. Specific behaviors observed as responses to the testing stimulus are given a numeric value. Your responsibility is to elicit the best response on each of the scales. The higher the scores, the higher the level of brain functioning. The subscale scores are particularly important if a patient is untestable in an area. For example, severe periorbital edema may make eye opening impossible. The total Glasgow Coma Scale score is the sum of the numeric values assigned to each of the 3 areas. The highest Glasgow Coma Scale score is 15 for a fully alert person, and the lowest possible score is 3. A Glasgow Coma Scale score of 8 or less generally indicates coma, and mechanical ventilation should be considered. The Glasgow Coma Scale offers several advantages in the assessment of the unconscious patient. It allows different healthcare professionals to arrive at the same conclusion about the patient's status. It can be used to determine between different or changing states. Although the Glasgow Coma Scale is the gold standard assessment tool for level of consciousness, other scales do exist and are also used. In cases of stroke or hemorrhage associated with increased intracranial pressures, use the National Institute of Health's stroke scale. Other key neurological assessments include cranial nerve assessment and motor and sensory testing. You will need to memorize the Glasgow Coma Scale so that you can apply it to a patient scenario as you might be presented with on an exam question. Here is an example. Calculate the Glasgow Coma Scale score A 31-year-old woman received a closed head injury during a motor vehicle crash approximately 6 hours ago. Her CAT scan indicates she has sustained a frontal contractile contusion of moderate severity to the left side of her brain. She is unresponsive to verbal commands, opens her eyes only to pain, withdraws to pain stimulus, and only occasionally makes sounds which are incomprehensible. Her blood pressure is 150/68, heart rate 72, and respirations are 28, and mildly labored. Please take a moment to calculate your Glasgow Coma Scale score for this patient. This patient receives a 2 under the category of eye-opening response because she opens her eyes to pain. She receives under verbal response a 2 for incomprehensible sounds. Under motor response, she receives a 4 because she demonstrates a motor response to pain. Adding up 2 plus 2 plus 4 gives us a grand total of 8 on the Glasgow Coma Scale. Remember, a score of 8 means severe disability. Oftentimes, the patient is in a coma, an unconscious state, where there is no meaningful response or no voluntary activities. Other key neurological assessments include cranial nerve assessment. Cranial nerve assessment is presented in a separate PowerPoint presentation. Assessment of reflex activity is covered in a comprehensive neurological assessment. Here we're talking about the oculocephalic reflex, or doll's eye movements. The patient's eyes are held open. The head is briskly turned from side to side, with the head held briefly at the end of each turn. A positive response occurs when the eyes rotate to the opposite side to the direction of head rotation, thus indicating that the brainstem is intact. In particular, we are referring to cranial nerves 3, 6, and 8. In the brainstem, these are intact. The eyes should gradually return to mid-position in a smooth conjugate movement if the brainstem is intact. The Babinski sign in an adult can also be elicited, and we do this by stroking the lateral aspect of the sole of the patient's foot, either with your thumbnail or another moderately sharp object. In a normal individual, this elicits flexion of all toes, and that's a negative Babinski reflex. With a positive Babinski reflex, the great toe dorsiflexes and the other toes fan out. So an extensor plantar response would be a positive Babinski sign, where the toes we have upgoing toes with plantar stimulation. The cause of this is due to some type of lesion to the upper motor neurons. So here is a reminder of what is normal on the left side of our screen when we elicit a Babinski reflex. Normally there's flexion, and then a positive Babinski, which we don't want to see in the adult, is shown on the right, in which the great toe dorsiflex and the other toes fan out. Another reflex that we assess for in our patients with, in particular, meningitis, which can lead to increases in intracranial pressure, is the Brudzinski sign. Remember, meningitis is swelling and irritation of the meninges, which are the membranes covering the brain and spinal cord. This inflammation causes changes in the cerebral spinal fluid that surrounds the brain and spinal cord. A positive Brudzinski sign is indicative of meningeal irritation. It is an involuntary flexion of the hip and knees. Okay, so when the healthcare provider lifts the head and from a flat position and raises the head of the patient, then we will see an involuntary flexion of the hip and the knees. This is a positive Brudzinski sign indicating meningeal irritation. And then we have Koenig's sign. This too is a sign of meningitis when present. Pain in the lower back and resistance to straightening the leg at the knee is a positive Koenig sign, indicating meningeal irritation. Compare the pupils with one another for size, shape, and movement, as well as reactivity. If the oculomotor nerve, which is cranial nerve 3, is compressed, the pupil on the affected side or ipsilateral side becomes larger until it fully dilates. If intracranial pressure continues to increase, both pupils dilate. Test pupillary reaction with a pen light. The normal reaction is brisk constriction when the light is shown directly into the eye. Note a consensual response, which means there is a slight constriction in the opposite pupil at the same time. A sluggish reaction can indicate early pressure on the cranial nerve number 3. A fixed pupil, unresponsive to light stimulus, usually indicates increased intracranial pressure. Other key neurological assessments include motor and sensory testing. Motor testing includes observing the tone, muscular tone. Hypotonia is the term used to describe a muscular flaccidity. Hypertonia refers to spasticity in the muscular tone. And then we have involuntary muscular movements, such as chorea and dystonia. Chorea is purposeless, rapid motions, and dystonia is impairment of muscle tone. Always note asymmetry of strength. In other words, is one side stronger than the other? Test motor strength by asking the awake and cooperative patient to squeeze your hands to compare strength in the hands. The pronator drift test is an excellent measure of strength in the upper extremities. The patient raises the arms in front of the body with the palms facing upward and eyes closed. If there is any weakness in the upper extremity, the palmar surface turns downward and the arm drifts down. This would indicate a problem in the opposite motor cortex. Asking the patient to raise the foot from the bed or to bend the knees up in bed is a good assessment of lower extremity strength. Test all four extremities for strength and for any asymmetry in strength or movement. The cerebellum is in the posterior cranial fossa below the occipital lobe. It coordinates voluntary movement and maintains trunk stability and equilibrium. Therefore, we need to assess balance and coordination. We can do this through the patient's posture and gait. Is this gait steady or unsteady? Ataxia also is a term used to refer to patients with cerebellar disease. An ataxic or staggering gait is one in which the feet are placed wide apart and the steps are unsteady. Dysarthria or slurred speech should be noted as well because it is a sign of incoordination of the speech muscles. Another way to test for coordination is to perform the heel to shin test. The movement should flow smoothly without jerking or hesitation. For the sensory exam, the patient should always have their eyes closed to avoid visual clues. The stimulus should be applied in a random fashion. For light touch, which is usually tested first, the examiner gently strokes a cotton wisp over each of the four extremities and asks the patient to indicate when the stimulus is felt by saying the word touch. Pain is tested by touching the skin with the sharp end of a pin. The stimulus is irregularly alternated with a simple touch stimulus with the dull end of the pin to determine whether the patient can distinguish between the two stimuli, that is, sharp versus dull. The Romberg test is done to test clients' equilibrium. That is what we are seeing in the picture here. You have the client stand with arms at their side and feet together. Have the client perform initially with eyes open and then with eyes closed. The nurse should stand close to the client to prevent falls. And the client should maintain a position for 20 seconds with only minimal swaying. Swaying beyond that would indicate that the patient has an equilibrium problem or problems with their sense of positioning. Another sensory test is called graphesthesia, and this is with the patient's eyes closed. You can write on their skin with your finger and you can see if they can figure out what word you are spelling. And then finally, stereognosis refers to putting an object in the patient's hand while their eyes are closed, having them identify the object that's placed in their hand. It can be a simple object such as a key or a pen. Motor responses may be used to assess the level of brain dysfunction and the side of the brain affected. Motor responses are accurate identifiers of changes in mental status. Initially, the client may be able to move purposefully away from a noxious stimulus. For example, to brush the examiner's hand away from the face. As function declines, movements become more generalized, withdrawal, grimacing, and less purposeful. Reflexive motor responses may occur, including decorticate posturing with flexion of the upper extremities, accompanied by extension of the lower extremities. With further decline, decerebrate posturing is seen, with adduction and rigid extension of the upper and lower extremities. Without intervention, the client eventually becomes flaccid with little or no motor response to stimuli. Record vital signs, including blood pressure, pulse, respiratory rate, and temperature. Be aware of Cushing's triad, which indicates severely increased intracranial pressure. Besides recording respiratory rate, note the respiratory pattern. Specific respiratory patterns are associated with severely increased intracranial pressure. In this diagram, we see common abnormal respiratory patterns associated with coma. Nursing diagnoses for the patient with increased intracranial pressure include decreased intracranial adaptive capacity, ineffective tissue perfusion, cerebral, and risk for injury. The patient with increased intracranial pressure and decreased level of consciousness needs protection from self-injury. Confusion, agitation, and the possibility of seizures increases the risk for injury. Use restraints judiciously in the agitated patient. If restraints are necessary to keep the patient from removing tubes or falling out of bed, they should be secure enough to be effective. However, agitation may increase with the use of restraints, which indicates the need for other measures to protect the patient from injury. Light sedation with sedative agents may be needed. Overall goals or expected outcomes for the patient with increased intracranial pressure include maintenance of a patent airway. Maintaining a patent airway is critical in the patient with increased intracranial pressure and is a major nursing responsibility. As the level of consciousness decreases, the patient is at an increased risk for airway obstruction from the tongue dropping back and occluding the airway, or from accumulation of secretions. Snoring sounds indicate obstruction and require immediate intervention. An expected outcome is to maintain an intracranial pressure and cerebral perfusion within normal parameters. Because malnutrition promotes continued cerebral edema, maintaining optimal nutrition is important. The patient with increased intracranial pressure is in a hypermetabolic and hypercatabolic state that increases the need for glucose as fuel for metabolism of the injured brain. Early feeding after brain injury may improve patient outcomes. Nutritional replacement should begin within 3 days after injury and reach full nutritional replacement within 7 days after injury. The patient's fluid and electrolyte status and metabolic needs should guide feedings or supplements. The patient should be kept in a euvolemic fluid state. Continuously evaluate the patient based on clinical factors such as urine output, insensible fluid loss, serum and urine osmolality, and serum electrolytes. Another expected outcome for the patient with increased intracranial pressure will be that they have no complications from immobility and as well as their decreased level of consciousness.